The United Nations University International Institute for Global Health. My name is Pascal Alote. I'm the director here at UNU IIGH, and we have a mandate to translate evidence to policy, to generate policy relevant and analytical tools, and to strengthen capacity for local decision making. Before we start the seminar, I'd like you please to turn your phones off or onto silent. If anybody didn't obtain permission from work before you came, please let us know, because we would like to tweet. So if there are any objections, let us know first, so we can blur your faces out. We also have a video recording of this because we want to begin to disseminate our work a little bit more widely. Again, if you have any objections possibly to appearing on the camera, please let us know, and we will blur you out, or we will make sure we don't focus on you or something. Welcome. We are very lucky today to have the director of Arrow, Siva, and Siva will introduce herself and a little bit of what Arrow does before we start. One of the things that we really pride ourselves in doing that many of the other UN agencies can't do is that we play with everyone. Whether it's the private sector, whether it's the civil society organizations and other NGOs, because everybody needs to be heard. Whether we like what they say or not, it is a really important part of our mandate, at least to bring that evidence together, to make it a part of genuine debate and dialogue for us to find the solutions that we need for the global problems. So Siva, please.
So thank you for coming. It's great to see so many people interested in this topic. This is one of the topics I'm deeply passionate about. So I'm the executive director of Arrow, and in my capacity in Arrow, what I've been doing over the past, oh gosh, it sounds like a long time, and I know it's not cool to stay in jobs for such a long time, but for the past 13 years. So I was part of the team that conceptualized and wrote the status of sexual and reproductive health and rights in conjunction with the International Conference on Population and Development Anniversaries. So ICPD Cairo, as you know, is the framework that kind of leads thinking on an agreement, because it was signed on to by 179 countries, including Malaysia and many of the countries in our region. So I was part of the group that wrote the Plus 15 report and the Plus 20 report, and now we're in the midst of writing the Plus 25 report. So the aspects that I'm going to share today are actually from those chapters that we have initially started writing on contraception, some aspects of maternal mortality, adolescent pregnancies, and abortion. Okay, so a little bit about Arrow. Arrow is 25 years old last year, so we're going to turn 26 soon. And we were set up 1 year prior to the Cairo conference in order to bring together the regional voices and regional organizations as part of the meetings leading up to Cairo. Okay, we work across 17 countries in Asia Pacific. We work with national level organizations to strengthen capacities in information, communications, research and evidence generation, and policy advocacy, right? So we work with national partners at the national level. We work at the regional level with bodies like UNU, UNFPA APRO, UNESCAP, and we also work at the global level, both in New York and in Geneva, which are the human rights spaces. So I look forward, as I said, this is the initial chapters of writing, so I really look forward to a lively debate and discussion after this, because I too am looking for ideas of what other enrichments can I add to the report, so it's a real value add to the community. So the title, I mean, we always like to talk about reclaiming and redefining rights. So why is it reclaiming and redefining? So reclaiming means actually the rights already exist. They exist in law, they exist within societal understanding. However, we don't claim it. So as long as we have to claim these rights. So this is why when we are working on an agenda like reproductive health and rights, we have to actually keep claiming these rights for ourselves. Redefining means that sometimes, unfortunately, these rights may not be extended to everyone in society, right? So we need to kind of redefine the parameters to include people from different sectors, right? And for me, of course, it's my personal belief that once you actually deny any group rights, it means we actually are denying the concept of rights on the overall, right? We start that slippery slope towards saying if they are cannot able to claim these rights, it means we are actually putting caveats on the rights themselves, okay? So arrow, yeah. So part of our work as we monitor international documents such as the ICPD Program of Action or the Cairo Consensus and the Beijing Platform for Action. This is the 25th anniversary of Cairo this year, and next year will be the 25th anniversary of Beijing. Yeah, so these are some of the key findings I'm going to look at. So what we can find is, as you know, access to contraception is very closely linked by demographers to total fertility rates, right? So total fertility has been declining steeply in all of the countries we study, but it's still high in some of these countries like Pakistan, Samoa, and Laos. And Pakistan, I think, had a slight increase in the new PDHS, so this is a very interesting observation that the DHS has come up with. So total fertility rates compared to wanted fertility rates are consistently higher for women living in rural areas, mountainous areas, lowest education quintile, and lowest wealth quintiles. Okay, so women who have less forms of power at their disposal face greater inequalities of fertility control even when they desire it. The same pattern is seen, you will see this socioeconomic inequities replicating itself in contraceptive prevalence rates and unmet need as well, right? So in all countries, we can actually see moderate contraceptive prevalence rates across the region, with the exception of China, which has a very high contraceptive prevalence rate. But this is also, we can consider, you know, is it because it's state-run and state-controlled, right? So we can actually ask questions on, did women actually desire that level of control, fertility control? And we can see that countries like Maldives, Pakistan, Samoa, Philippines are quite on the lower side. So even in Malaysia, you have 52% of Malaysia reports 52.2% of a contraceptive prevalence rate. However, we do not actually have a methodology where we systematically collect the data, and it is basically, if I'm not mistaken, derived from one demographer's work, which is Tene Ping, and it does not take into account the newer methods. So they don't look at service providers like private pharmacies and all of that. So if consumer health behavior has changed, this is not being tracked or monitored. Because you will ask, why is it the contraceptive prevalence rate is low and then our fertility rate is also low, right? So, okay, so these are some of those anomalies that we will find. But in that we collect, by this one, it only says that they use 34% of modern methods and 17.9% of traditional methods. As you know, so it shows a heavy reliance on traditional methods. The ICPD promised a range of contraceptive methods to women, and informed choice still seems distant to many women. So the number that makes up the contraceptive prevalence rate is made up of all of the methods. Okay, so you have modern methods and traditional methods. The modern methods you will have sterilization, IUD, injectables, oral contraceptive pills, and all of that, right? Inside the traditional methods, you will have rhythm, withdrawal, okay, those count. So, and then you will also have condoms inside the, modern methods. So, But if you look at this contraceptive, so women are supposed to have a choice to the method they desire, right? But if you look at the high contraceptive prevalence rate countries, you will find that there will be a preponderance of one method over others. Okay, what does that mean? So in China, you will see IUD and sterilization lead the way. Vietnam, it's IUD and traditional methods. So if women only have a choice between IUD, they know IUD, they have to resort to traditional methods. What does it mean except that there is no choice, right? So there are two things. One is countries that we don't see access to contraception at all, but when there is access to contraception, it is a predominance of what the state decides to provide, not really what women may desire for themselves. Informed choice on contraception methods and side effects have not been emphasized in service provision. So informed choice is actually an indicator that comes up with three different kinds of things you look at. Were you informed about the choices of methods? What were the actually side effects of the choices of methods? How do you know you're experiencing the side effect? And what to do if the side effects occur, right? So these are the three types of information any service provider is to give any person sitting in front of them for when they're accessing contraception. However, data will show us that this information is sadly missing. Even in countries where you have high contraceptive prevalence methods, the one where they really are informed about all of these three types of information is in the case of sterilization, because they say you can't have children, and right? So this is basically what they have to inform. So the four things that really affect whether women use contraception or not are actually concerns about side effects, health consequences, inconvenience of methods of contraception, and non-use due to opposition, right? So male contraception remains at very low levels, although condoms offer dual protection against pregnancy and disease despite the context of HIV/AIDS. So male contraception is nowhere near the desired ideal of having equal responsibility being shared over contraception and family planning. Oh, shucks, I'm doing too fast. Okay, yeah, so Vietnam has the highest, so 11.2% of all methods come from male contraception. Nepal, Maldives, and Pakistan is about 9 to 10%, and it's very low in Cambodia, Laos, Philippines, and Thailand. So interestingly, Maldives and Pakistan, earlier I showed you, right, that they have a very low contraceptive prevalence method, but so almost like 1/3, so it was about 33%, right? So if they are recording about 9 to 10%, it means that almost 1/3 of their method is dependent on condoms, right? So I think it is more about cultural acceptability towards condoms within that context. And interestingly enough, in Cambodia, Laos, Philippines, and Thailand, which is kind of known as the HIV area of the Mekong region, right? And yet there is a low utilization of condoms. So why does this occur? If you read the demographic health surveys, they actually give us the information that use of condoms between couples implies mistrust. So if a woman asks the husband to use condoms, or if the husband tells the wife, I'm going to use condoms with you, it means that they're not faithful to each other. So they don't negotiate that because of this baggage, right? So then you have this other indicator called unmet need, right? So the definition of unmet need, and so if you have contraceptive prevalence rate, there are all these people who need contraception but they're not using contraception. This is what is called unmet need, right? So one of the big gaps in our contraception data across the region is that all our data sets only involve married women. So they do not touch on unmarried women at all, except in the Philippines and in Cambodia, where they actually include unmarried women inside this data collection. Moreover, it is only collected for women between reproductive ages of 15 to 49, right? And if many of you are doing research, you will understand that people are not wanting, there's a lot of barriers in order to collect the data for people who are below the age of 15, to ask them questions about their sexual and reproductive behavior. And then also there is this assumption that after 49, there is no sexual reproductive behavior as well. So these are big gaps. Okay, so there's the age gap, and then there's the marriage gap. Then unmet need does not take into account the unmet need for STI. It's only for pregnancy prevention, but there is no calculation for what is unmet need for STI prevention. And there's also something called fertility desires, which I will talk about later. So again, women with lower or no education, poor women, women who live in remote and hard to reach areas had less access to contraception and less control over their fertility compared to their educated, wealthier and urban counterparts. Okay. I forgot to just try to look at my notes, sorry. So since the next slide goes on to another topic, I better tell you all about this fertility aspirations. So in some places where data is available, like for example in the Philippines, you can see that men desire to have more children than women. So women may turn out wanting only 2 children, but they may end up with 3 children or 4 children because their spouses desired more children than they did. And when they desire more children, then the onus on contraception and family planning falls solely on the shoulders of the woman herself, right? So the spouse may not actually cooperate. The other thing that in this wealthier counterpart, so Philippines is one of those countries that shows this really huge gap. In most of the countries, those women who belong to the lowest wealth quintile or the lowest education quintile or from the rural areas usually have 1 child more than they desired to have. There's a comparison between wanted fertility rate and total fertility rate. However, in the Philippines, you will see that in that lowest wealth quintile, the lowest educational quintile, the difference is actually to the number of like 3 children. They had 3 children more than they wanted to have. So the inequality is so huge, you know, because to have 1 child, maybe people may think that it's not a big deal, but to have 3 more than you really wanted to start off having is actually very large. It is due to both the fertility preferences of the male as well as their lack of access to the essential services. So pregnancy and childbirth related mortality and morbidity, right? So what do we find? So as you know, contraception is closely linked to maternal health, but it's not, similar. So MMR is high in countries such as India, Pakistan, Nepal, Bangladesh. Bangladesh has reduced quite a bit. Laos, Cambodia, and Indonesia, right? So the ICPD target was MMR below 100, and only Malaysia and China have accomplished this in our so of course New Zealand, all that as well, but they're not in our set. Progress can, so the problem with MMR, as you know, is a number of countries are using estimates, right? So there are different estimates and different baselines to this, and different numbers through national WHO, UNICEF, UNFPA, and UNDP sources. And then for the purpose of the cross-country comparison, we are using the WHO, UNICEF, UNFPA data. So the reason for this is most of the countries do not have a vital registration system. So if you have a vital registration system, you actually record all the births and all the deaths that take place in your country. So you can actually make an estimate, right? However, in most of the countries where the vital registration system doesn't exist, they have to use the method of estimation. And estimation have wide confidence variations, so you may not actually get the exact number, right? So when you do have a vital registration system, the method that's used, like for example in Malaysia, they will collect all of the maternal deaths data. So this is one of the countries that if you die during delivery or during the course of your pregnancy, it actually becomes a sort of a police case, right? It is the one case that the police will come and ask the doctor what happened. I mean, like even if you die during heart surgery, that doesn't happen, only during this. So, and then from there, it is determined whether it's a maternal death. Every 3 to 4 years, there is a confidential inquiry. Right, so they actually put all of the deaths and then they assign the sources, what are the cause of death, right? Was it hemorrhage, was it unsafe abortion, or whatever it was. And then from there, they can actually take the appropriate action, right, within the monitoring. So that is like a very comprehensive, but not all countries have this. Of course, you may wonder if maternal mortality has been an agenda from the 1950s and 1960s, why have the governments not done that? So that comes to the end part, right, of our recommendations. So even when you have a national MMR that may look better or has improved, you will actually find that there are variations within the country, right? So India may have shown as being reduced, but you know that Uttar Pradesh, Bihar, Jharkhand, Orissa, Madhya Pradesh, Rajasthan are very high MMR states, and then you will have lower MMR states like Kerala, Tamil Nadu, and all of that, right? Then in China, even though China has a very low MMR, but the western provinces will show a higher variation, okay? So the lifetime risk of maternal death is lowest in China, which is 1 in 1,300. So the interventions that prevent maternal deaths include access to emergency obstetric care, skilled attendance at birth, and postpartum care. So this is all part of the UN process indicators. However, it is not taken up inside reporting mechanisms such as MDGs and SDGs. So while in the SDGs you have governments reporting, right, how much the MMR is, because it's one of the SDG indicators. However, you will not find exactly what that attribution of MMR has been to, right? So whether average citizens or marginalized citizens are able to actually access health services that are necessary is something that we cannot understand by these reporting systems, all right? So skilled attendance at birth is one of those things. The ICPD target was 80%, and it's less than 50% till today in Afghanistan, Lao PDR, Bangladesh, and Pakistan. So professionalization of midwifery and increased number of births with a skilled attendant backed by facilities providing AMOC is associated with a declining MMR. Okay, so while in the MDGs you had antenatal care, you almost had no mention of postpartum care. But postpartum care is actually one of the critical interventions. So this is why I say, like, sometimes the international reporting system may not actually give us clues or indications to exactly which specific intervention that needs to be looked at. So postpartum care is also critical. 25 to 33% of all maternal deaths are actually caused by obstetric hemorrhage, generally occurring postpartum, that is within 24 hours to 2 days after delivery. So this is antenatal care. And we all show a very, I wanted to show you, all the countries have very high antenatal care. So Indonesia has 92% antenatal care coverage, but they have a very high MMR. So it's not to say that antenatal care is completely not predictive, but generally it is not useful, it is a useful intervention, but antenatal care, how they count this is they visited 1 visit, 4 visits, right? So it's not like as many visits as you need, but 1 visit alone, it already says you have coverage, but it may not be enough. But of course, maternal death is a bit more complicated than just receiving antenatal care. Okay. So in this time period, this hemorrhage, hypertensive disorders, and cespis were responsible for more than half of all the maternal deaths, which is why that postpartum care is very essential, right? And hemorrhage was the leading cause, and more than 2/3 of reported hemorrhage were classified in the postpartum period. So now, but we also find a new trend. This is embolism is emerging as one of the causes in countries such as Malaysia. So this is something that you actually never saw in the data sets earlier, maybe because they were not catching it, or it masqueraded as something else. But this is tied with perhaps a rising obesity epidemic in the region. So we will probably see embolism emerging in other countries as well, but in the next few years. So maternal morbidity. So a lot of attention is on maternal deaths, But there's also the aspect of maternal morbidity, which is very less looked into, and it accounts for nearly 31 million disability-adjusted life years are lost annually. And the most common, of course, obstetric fistula and uterine prolapse. And fistula is often occurring in first pregnancies of young wives, okay, in early marriages who lack education and access to services. And prolapse often occurs in higher Paris women, right? And then current interventions focus on medical treatment, but also that sufferers of fistula and prolapse also need much more support services, welfare services, as well as counseling, right? Okay, so adolescent pregnancies. It's going to be a very long section. Okay. So, and then this is where I stop doing all the fancy things, so you'll only see a lot of text. Okay, so 25 years ago, the ICPD brought actually adolescence as a demographic critical to the development to light. Okay, and the ICPD mentions the rights of adolescents with regards to the right to education, especially secondary school education, the right to sexual and reproductive health information, services, and full and free choice in marriage-related decisions, the right to be free from gender-based violence, and the right to be equal within family and community through gender-equitable roles and attitudes. This is a very big promise. So 25 years later, where are we? You can see in many of the countries, adolescents still remain as one of the most neglected and marginalized groups, okay? The WHO defines adolescents as those between 10 and 19 years of age. The great majority of adolescents are also included in the age-based definition of child, as defined by the Convention on the Rights to the Child. Okay, so adolescence is one of the most pivotal phases of life. The structure of life that affects adolescence, both in health and gender, has consequences over the entire life cycle. So what happens to a person between the ages of 10 and 19 will actually determine their sexual and reproductive lives till the day they die, right? So vulnerabilities and marginalized faced in adolescence within the family, community, and the larger society are repeated and augmented throughout life. As such, adolescence needs explicit focus for gender and health interventions and are often left out of programmatic focus due to social biases, right? And then the adolescent population in the region is very large, okay? In 2017, almost 1 in 4 persons, that's 25%, in Asia was below the age of 15. And 29% in Southern Asia, there's 1 in 3. And in 26% in Southeast Asia are below the age of 15. So whatever information, health, whatever interventions we do, if we are able to serve this young age group, it will actually give us many benefits over the entire life cycle. Okay? So of this large population, of course, half of this population are girls, and then girls suffer from the double burden of both age and gender. So they are marginalized through age because generally in our region and in our societies, young people are not actually supposed to give their opinion or challenge the elders, or they're supposed to conform, right? So it's an age of conformity, basically. Girls may be doubly asked to conform because they're girls, right? So you have to behave in a certain way, you can only go to certain places, you're not supposed to talk to boys, so all of that. So that's what is called the double burden of both age and gender. And if you actually put across this entire web of what is called intersectionality, or in public health perspective, it could be social determinants of health. So if you put poverty, geographic reach, migrant status, minority status, then you will see that some girls are further disadvantaged due to that, right? And if you know the story that came out in the press of that young girl in Kelantan who got married at the age of 11, it is because she was also migrant, right? So because she was migrant, she's not allowed to go to school, she can't access many of the normal opportunities that even girls at the age of 11 can do so. So that actually kind of exacerbates and what leads that family to decide that perhaps marriage is the best thing for her, right? So we need to analyze it from many different angles. So, yeah. So one of the things that we can find in our region, which also kind of, in addition to not only gender roles, is that we are a region known for son preference, right? So son preference is basically sons in the family are preferred and more resources are invested in them. So saying goes that, feeding your daughter is like watering your neighbor's garden, because girls, after they get married, actually go and live with the families of the spouse, and they do not contribute back to the families they were born in. So this kind of drives this idea that there should be lesser investment in girls, right? So this is, so now we go to actually the adolescent pregnancy part of it. So adolescent birth rate is the number of births that take place per 1,000 women ages 15 to 19. So early childbearing carries with it grave risks which are usually taken without the full understanding and choice of the girls themselves. Sometimes girls who are giving birth don't realize exactly what they're putting themselves through because they never receive the information, right? The chance of adolescent girls dying in childbirth is twice as high as that of a woman who waits till her 20s. Okay, in order to give birth. In addition, there are other risks: premature labor, complications during delivery, low birth weight, and infant mortality, as well as morbidities, especially vesico-vaginal fistula, which we talked about. I think in one Malaysian study, the researchers also found that the children had higher perinatal morbidity as well as lower APGAR scores, right? So early childbearing also greatly reduces the likelihood of a girl advancing in her education and limits her opportunities for training and employment, and often confines her to the domestic sphere for a number of years. So early childbearing is closely connected to repeat and frequent pregnancies because her reproductive life is longer within the marriage, right? So these are some of the numbers we can see. And we can see that adolescent fertility is a major concern for governments, and generally many governments do have policies or programs in order to reduce or control adolescent fertility. Bangladesh, India, Indonesia, Laos, PDR, Malaysia, Nepal, and Pakistan. These are the governments who actually have policies on them. And Malaysia may have low numbers overall, but we know that what this one is like 19,000 births. So 19,000 births annually would counted in 2009 and 2011. This is the famous number in Malaysia. This is a lot. This is a large number in a country which has universal access to education, right? And all of the development structures are at least in place, right? So why does this occur? And it is a concern, as you know, right? So in most of the countries in the region, adolescent pregnancies and births occur within the context of marriage. Adolescent birth rates are also higher in countries that do not strictly enforce the legal age of marriage, right? So there's a connection between the attitudes towards marriage and the adolescent pregnancies. So if we look at met need for contraception, we can see stark differences. If we look at met need, 15 to 19 are the ones who have lowest needs met, because either due to the pressures that they have to prove their fertility within the union as fast as possible, or two, because of the lesser autonomy and lesser rights that they may enjoy within the family in order to say that I want to delay my pregnancy, and it's something that even, of course, younger girls may find it very difficult to do, right? So we can also say that, so this is what I've already said, okay. So, and if you also interrogate the data further, you can break down the data as to like they wanted the pregnancy then, they wanted it later, or they never wanted it at all. So mistimed pregnancies are usually highest in that 15 to 19 groups, and when the age of marriage rises in countries like Vietnam, so it goes to the next one, 20 to 24 will show you the pregnancies. They actually wanted to get pregnant later, right? So it was mistimed. It was not unwanted, but it was mistimed. this is the one. I think I'm ahead of the slides. Huh? Okay. Okay, so yeah, sorry. So this is one where we were talking about early age marriage. So adolescent pregnancies in the region, most of them are actually within the context of marriage. So there is a thing to think that, you know, adolescent pregnancies or teenage pregnancies are occurring outside of it, but it's not true. It's actually talks about the status of girls themselves, right? So governments across the globe have committed and they keep committing and recommitting to the agenda of preventing and eliminating child early and forced marriage. However, the practice continues in many key countries, right? So in September 2014, the UN General Assembly, that means all the member states of the UN, including Malaysia, adopted unanimously a resolution on child early and forced marriages. So the key barriers to actually ending and eliminating child marriage includes lack or inability to enforce. Minimum age and legal age of marriage are difficult to enforce in countries which do not have a vital registration system, right? Where girls may be presented as being of the right age when they're to get married, but there's no way of checking it. Multiple laws may coexist on the age of marriage: the civil law, religious laws, and cultural indigenous traditions and laws. Others often providing exemptions and see that minimum age of marriage being flouted. Okay, there are exemptions in every single country. Every single country that we looked at, it regards the legal age of marriage, with the exception of China. So let us look at ASEAN. So this is a scenario that we are familiar with. The majority of ASEAN member states have legalized exceptions to the general minimum age of marriage, and all of them have quite a high burden. Not all of them, most of them. Lao PDR, although nobody talks about Lao PDR, but there's a huge number of early marriages occurring in Lao PDR. Indonesia, Malaysia, right? Exceptions may be granted for a wide range of reasons which vary from state to state, but are generally based on the grounds of religion, ethnicity or custom, physical signs of puberty, that means she looks like she's ready to get married, parental consent, so sometimes the parents wanted them to get married, pregnancy, the girl is pregnant, or other broadly defined or undefined reasons related to the personal circumstances of children, couples, and families. So we have seen actually in Malaysia, they've also cited like the girl is already dating the boy, so she needs to get married, right? Or my child is wild, you know, so you better get her married because marriage cures wildness. I don't know, okay? Yeah, so both the Convention on the Rights of the Child Committee and the CEDAW Committee have consistently expressed concern about exceptions in law to the general minimum age of marriage. So in some cases, the marriage laws explicitly exclude jurisdiction over particular religious or ethnic groups. So in Brunei, the states the law does not apply to Muslims, Hindus, and Buddhists, Dayaks, and other persons governed by their own laws or customs of marriage which are recognized by Brunei law. Right? So, Section 3 of the Women's Charter Singapore provides that particular sections of the Act, including Section 3 that establishes the minimum age of marriage, do not apply to persons married under Muslim law. Okay, you can see the same is in Malaysia, stipulates the law does not apply to Muslims and those married under Islamic law, any native of Sabah or Sarawak, because actually you can see in Sabah and Sarawak there's a high number of early age marriages which are not Muslim. So, or contracted marriage under the Christian Marriage Ordinance or the Church and Civil Marriage Ordinance. So that's where this is falling under. The Section 1448 of the Civil and Commercial Law in Thailand specifies that the court may, in case of having appropriate reason, allow marriage applicants to marry before attaining such age, which is the legal age of marriage. So there is no further clarification of what this appropriate reason may be. I'm assuming I'll go back to that earlier, looks ready for marriage, so can get married. Yeah. So the conservatives, of course, across all countries argue that the law concerning minimum age of marriage may serve the best interest of the individual children, in particular cases, providing that the consent is clearly established. So one thing is we have never actually gone and asked the girls, did they really want to get married? Did they actually know what other options existed before them to say that, you know, so in many of this, the consent is not clearly established. For example, if you take a 17-year-old who becomes pregnant, then of course the community and her parents then determine that the best thing for her is to get married, right? So, but does she have options? Of course she has options, right? So, and as you know, some of these loopholes have actually been utilized in order to allow rapists to marry the person that they raped. So early marriage is a strong indicator of the autonomy within the marriage itself, and the relationship and the family. So early marriage goes hand in hand with exclusion of girls from the decision on when and whom to marry. So evidence in India, there's a study that they did, which shows that compared to young women who had married at age 18 or older, those who had married early were less likely to have been consulted on the timing of the marriage, who they wanted to marry, as well as had an opportunity to get to know their spouse before marriage. So if you got married early, this did not happen in India. Okay? Early marriage is both a predictor and indicator of the status of girls. So, So younger married women are more at risk for violence. Okay, this is a 10-country study demonstrated. This is a 10-country study which was done across looking at demographic health surveys. Demonstrated that the age at first marriage is a major factor related to experience of violence. So women who were younger than 20 years old when they first married or started living with their current husband or partner were more likely to report physical or sexual violence than those who reported being 20 years or older when they were first married. Data from the WHO multi-country study shows that 20 to 36% of women ages 15 to 19 years old cited being reported at least one act of physical violence in the previous years as compared to older age groups, right? Younger girls who marry at an early age often have negligible sexual experience, lesser information, no autonomy, and little negotiating power within the relationships. So an Indian study showed that only 1 in 7 married girls aged 15 to 19 could go to the market. Only 1 in 7 could go to the market without her husband's permission. Okay, and only 1 in 10 could visit friends without permission of the husband. Twice as many older married women had the freedom to do these things. Was still very little freedom lah, but younger girls have got more freedom. I mean, I think that there is no need to ask anybody's permission to go to the market or visit your friends. Okay. HIV and STI risks are higher. So for younger girls, their partners are often older. For example, in Bangladesh, the mean age difference between a married girl aged 15 and 19 and her husband is 9.8 years, and he is more sexually active. This puts younger women at greater risk of contracting reproductive and sexually transmitted infections, including HIV. So young people at higher risk of HIV infection who are in relationships with older partners are more likely to have unprotected sex than those with partners of the same age, because they cannot negotiate, right? Because they're young, and are more likely to be HIV positive. So lower educational attainment for girls, these are other things which are, of course, limiting their employment opportunities, economic security, and productive value to society. These are some of those other issues. So some of this data, as you can see, I mean, relates to the situation that we are also in, we find Malaysia in, right? So this is why I wanted to present to you also that you understand that this is a regional trend. So we don't have to be so parochial in our thinking and say that these interventions or these problems are in a particular community are due to certain religious beliefs or biases, or but this is actually a regional issue. So although abortion is considered contentious, it is an integral component of reproductive health services. So access to safe and legal abortion remains one of the biggest challenges for women across the globe, and it is important to recognize abortion both as a public health issue and a human rights issue. So the CEDAW committee said that unsafe abortion is a leading cause of maternal mortality and morbidity. As such, state parties should legalize abortion, at least in the cases of rape, incest, and threats to the life and or health of the mother, or severe fetal impairment. as well as provide women with access to quality post-abortion care, especially in cases of complications resulting from unsafe abortions. State parties should also remove punitive measures for women who undergo abortion. So in countries which have very, very strict laws on abortion, and I think the case we know of is of Nepal, because Nepal rather recently legalized abortion, that women can actually be jailed for even miscarriage, right? So because you did not know it was a spontaneous abortion or an induced abortion, so you could be jailed for miscarrying. I think that we will see certain trends like this in the United States soon because of the kind of clamping down that they are doing on their abortion access. So 4 countries in the region, Cambodia, China, Nepal, and Vietnam, have abortion available on request. On request means that you do not have to provide any reason, you just request it and you are entitled to receiving the service. But only in many other of the countries there are certain grounds. But only in Bangladesh, Indonesia, and the Philippines is it available on extremely limited grounds, which make it almost impossible to access the services. But there are other ways around it, of course, which we'll come to later, I hope. Okay. So these are some of the changes in law and policy since 1994, since ICPD. So Vietnam legalized abortion and menstrual regulation in 1989, Cambodia in 1997 due to high MMR. Okay. In 2002, Thailand broadened the grounds to include reasons of mental health in 2005. Indonesia amended grounds for abortion to those who had been raped in 2009, but these limits are very, very inadequate because it says that it has to be performed within the first 4 weeks. And if you know how pregnancies are termed, the first 2 weeks is actually from your last menstrual period. So which is why you will know that this girl who was raped by her brother and found herself pregnant, and her mother took her to get an abortion, she was jailed, right? Because it's such a narrow time period for you to see, where it's legal for you to see, even for the cases of rape and incest. And then I think Fiji also had amended in 2009 to include 4 grounds of rape, incest, and fetal impairment. So the lack of knowledge about abortion laws among women and service providers continues to be an issue, and this is also the same case in Malaysia, because in Malaysia abortion is a service that can be given for a variety of reasons, including mental health reasons. So pregnant adolescents have an option, right? However, there are some limitations because most fatwa says until 120 days. But for reasons of like fetal impairment, there are private sector hospitals who use the mental health reason in order to provide abortion services. So unsafe abortion is negligible in countries which have very liberal abortion policies such as China and Vietnam, but it continues to be a major factor in maternal deaths in regions, contributing almost 14 to 13% of all maternal deaths in Southeast Asia and South Asia. So this is what makes a safe abortion, unsafe abortion, right? So WHO defines it into 3 categories: safe, less safe, and least safe. So safe means you got the right method and a trained provider. Less safe means you got only one of those. And least safe means you got neither, right? So those are the 3 definitions. There's a lot of words to describe that. Okay. So although access to safe abortion services has been proven to be linked to a lower incidence of unsafe abortion and lower percentage of maternal deaths, yet the progress on amending the laws or providing services seems to be very slow. Okay? So it is useful to note that abortion services are provided safely through the private sector in many countries and through family planning methods such as menstrual regulation. So Bangladesh, interestingly, although they have, they say abortion is illegal, but menstrual regulation, which is actually MVA, which is a manual vacuum aspiration method, is very widely available. And menstrual regulation is basically you need to get your period back, right? And performed safely within 12 weeks of not getting your period, right? So you have, and now they have actually made it legal for menstrual regulation with medication abortion, right? So you can do it, previously it was with the MVA, but now you can also do it with medication. And these are legal. So there are always options, right? So in Lao PDR, the Philippines, Indonesia, Bangladesh, it's the legal barriers. In Malaysia, there's non-legal barriers such as hospital administration policies. And in countries with liberal policies such as Nepal, India, and Cambodia, service barriers or quality of service barriers for safe abortion still exist. And this is what actually causes the unsafe abortion to occur. So the role of health providers is really essential. Health providers play an important role in the provision of abortion services. However, in the region, there's both a shortage of health providers and an unwillingness or bias of service providers, which can make it difficult for women and girls to access services and further stigmatize the services, right? So in Southeast Asia, healthcare providers have moral, social, and gender-based reservations about induced abortion. And these reservations influence attitudes towards induced abortions and subsequently affect the relationship between the healthcare provider and the pregnant woman who wishes to have an abortion, right? So healthcare providers often persist in viewing induced abortion as immoral, okay, rather than recognizing the legal status of abortion in their country and supporting women to obtain the services that they seek. So what are some of the conclusions that we can make? So progress, we can see across the region is uneven, slow regards sexual and reproductive health and rights. And then, so no one country is uniformly very progressive in every single indicator. Contraceptive prevalence rates, where they are available, show burden of contraception falls on women, and poorest women for living in rural areas, lesser educated, actually are facing the lack of access. This is also true in our country. And so access to contraception is not only about gender equality, it's also about socioeconomic equity. So access to contraception is curbed by many factors, including social paradigms. We talked about who can get this access and who cannot get this access. And then abortion policies take a long time to change, and progressive laws must be backed by service provision and quality of care. So maternal deaths remain still unsolved, okay, and then adolescents and young people are very much neglected in every country in the region. Okay. So what is really important is political will of governments is crucial. So we can see that political will of governments has been really important. So wherever this progress has occurred, the government needs to exert its influence behind it. So whether it is fertility reduction in China, India, Indonesia, maternal death reductions in Malaysia and Thailand, safe abortion service provisions in Vietnam and China, reproductive cancer prevention, treatment and care in Malaysia, VCT and ART service provision in all countries, and STIs has been driven by government as well, of legalization. So if the government wants to do it, they can even legalize and recognize same-sex relationships and transgenderism as being done in Nepal, and now also India and Pakistan have followed suit in recognizing third gender identity. Yeah? And then, so once the importance of the issue is established, governments create policies and programs and deploy budgets and train personnel and provide facilities and access in order to make that happen. Unfortunately, this is taken like, issue-wise rather than an overarching view of recognizing the full right of citizens to sexual and reproductive health and rights. Access to marginalized groups is a concern across all countries. So again and again, whether it's maternal health services, contraception, whether it's safe abortion, women who are poor, less educated, live in remote areas and or rural areas face greater difficulties in accessing services and realizing the autonomy of their bodies. Adolescent girls and young women are especially neglected, and this happens. They're neglected, whatever. Even if they're married, it's hard for them to get contraception, maternal health services, whatever it is difficult for them to get it. Sexual and reproductive health and rights are an issue of socioeconomic inequity. So the rights framework is essential to make progress. So all countries recognize women's right to bodily integrity and freedom from sexual violence in one way or another. All countries recognize rights of choosing partners and entering into consensual marriage, right? But as I said, there are exceptions to recognizing this. So politically, governments are comfortable recognizing the reproductive functions of sexuality. So when they make their policies, their laws, and their programs, if reproduction is occurring within the framework of marriage, they are very comfortable recognizing it. They are lesser so recognizing it outside the framework of marriage, and giving rights to those who are operating outside of this. Okay. The non-reproductive functions of sexuality are considered secondary and have not been attributed commitment and importance. So rather than look at where this activity is taking place, to consider it as the right of citizens, right? However, as seen with adolescent girls, recognizing the rights of such groups, even right to information, right to comprehensive sexuality education, right to access both contraceptive and abortion services, will enable us to actually make that final lap, right, in looking at reduction of maternal mortality, or providing healthcare access, or ensuring girls stay in school, or able to realize their full spectrum of rights. So what are the recommendations we can give them? So policy change underpinned by commitment to, of course, frameworks such as ICPD and Beijing with respect to reproductive rights and sexual rights, right? So policies need to be mainstreamed, looking at this range of services. Policies should be implemented and backed by functional health systems, as I said, vital registration systems, referral systems, and then SRHR policies need to be created and reviewed in circular spaces. Policy review processes need to be integrated with CDOR and ICSR reporting mechanisms to actually move the governments to recognize rights, because it's an important aspect. And then policy review should be underpinned by the human rights paradigm, and policy review efforts should integrate good practices in the region so we can learn from each other, right? And performance benchmarks and engage in knowledge sharing. And there's more. So when we talk about universal access, so a lot of people, as you know, there's universal health coverage, but we also want to talk about universal access. When we say universal access to affordable, quality, gender-sensitive services, we actually mean everyone has ability to access these services, right? Yeah. The gap that we find in many of the governments is the fact that there are the rights to sexual and reproductive health, especially of adolescents and marginalized groups, as well as LGBT, are actually not recognized fully, right? By creating adolescent-friendly policies, ensuring comprehensive sex or sexuality education, and removing barriers of consent and discrimination. Create comprehensive programs, policies, and plans to address these marginalized groups who will require more than one intervention to improve their SRHR. So implement policies and programs with an understanding of different aspects of vulnerability. Okay? I think. Was that right? Yes. That's all.
Stay there. Question.
Have you said earlier in the earlier?
Can you stand up and say who you are?
Sorry. My name is Madiha. I want to ask you about in this earlier slide. You have said about social bias. Can you explain it a little bit more on that?
So social bias with regards to adolescents, right? Yeah. So for example, if an unmarried young person goes to a clinic and says, I want to access contraception, so the first question that is asked is, are you married, right? In fact, in a number of these family planning clinics as well, it's actually said there, right, if you are married, only you can access it. So this itself is like a bias. This is a social bias which has been kind of implemented inside a policy framework. right? So sometimes if you look at 19,000 girls who are getting pregnant, and if we understand where they came from, we have to look and think that would have accessing contraception made a difference to preventing that birth? Right? So that's what I mean by social bias. Does that make sense?
Yeah. Thank you.
Can I ask a question as well? So you have been involved in these processes for a few years. And you, with a few of the slides, you sort of pointed out where there'd been policy changes for various reasons. Is it actual data that shows trends or whatever about whether with increasing access to abortion, the demand for it changes, mortality, morbidity changes, and so on?
Yeah, definitely, because if you look at it through the trend analysis, so for countries like Bangladesh, although their services may really not be as comprehensive and have full coverage, you can see that they were able to reduce their maternal mortality due to the fact that they have a high contraceptive prevalence rate and the wide utilization of menstrual regulation, which is almost like very accessible. So that's where the maternal mortality reduction, was really able to happen. So, and then I think the increase, Nepal and Cambodia also show this steep declines in maternal mortality reduction because they were at 300 or 400 before. The MMR was like 300 or 400 before legalization of abortion, and now it's come to about 116, 117. So it's really, you can see that, the data does show that.
Oh, now the hands go up. Can I start from that end and we'll work our way in? Yes?
Thanks so much. This was such a great comprehensive overview and really insightful, so thanks for that. I had two of my questions and one comment question. I was curious if you looked into female genital mutilation as well. The other question was, you were mentioning already about male involvement in participation in contraception, specifically looking at condoms. Did you look at vasectomies for men who are older and have reached a number of children? The general point was around the choice for contraception and the methods that people are using. I was wondering if you had sort of looked at that or maybe overlaid that with data on what is covered under the universal health coverage schemes and how that is influencing the set of choices.
So I think, firstly, the universal health, I'll answer the second question because this is fresh in my mind. So the universal health coverage schemes are not in place yet, but you're absolutely right. So across all of the DHS, provider bias plays a very powerful role in how women actually choose a contraception. So in some countries, definitely we know of like India and Vietnam. So Vietnam, the choice of IUD is driven by provider bias. In India, the incentivization that the government gives to providers to actually report on certain numbers with regards either IUD or sterilization or now beginning like injectables, right? So in Indonesia, this actually drives women's choice of method. So the preponderance of one method is very much due to that, So we can say like, even if we say that the demand is satisfied by modern contraceptive methods, but demand is satisfied, was it actually from the woman's point of view? Did she get a method that she wanted? We are not. We do not know that yet, right? Okay, that's first. The second one is FGM. So FGM, as you know, Africa received a lot of attention on FGM. Lesser handle is of course Asia, but I think that now we're actually seeing a lot of advocacy arising out of that. It is a common practice in, let me recall this from the top of my mind, from other things that I've written, which is not here yet because I haven't written that chapter yet, which is Malaysia, Indonesia, Maldives, and then the Bora communities of Pakistan and India. It also happens in southern Thailand and southern Philippines. Yeah, I've got them all. Yeah. So, in a number of these countries, because it is not considered the extreme forms of FGM, it is lesser recognized. I think that there were 2 studies or 3 studies done in Malaysia itself, which actually talks about almost 80 to 85% prevalence rate of female circumcision. So this is an agenda that clearly needs to be taken up, because there are a number of Muslim majority countries where, like Bangladesh, it is not practiced at all. Pakistan, it is not practiced at all, except for in the Bohra community, which is very small. And then, of course, we know that there are huge movements of getting religious leaders in countries like Egypt and across Africa to say that this is not a practice that is subscribed by religion, right? By religious beliefs. So I think that there's a lot of work to do. Unfortunately, the countries like Malaysia and Indonesia have actually decided that under the voluntary SDG review process that they're not going to report on this indicator. So that's some room for advocacy for us.
There was a third one on contraception.
Male contraception.
Yes, so we talked about condoms, but vasectomy, I think the highest number of vasectomies is, I think, in Nepal or something like that. So yes, but across all other countries it's like 0.1%. Yeah.
The next, moving to my right. Yes?
Hi, I'm Gabby. I just wanted to ask about multi-sectoral action when it comes to access. I know there's movements like rural female programs, and also microfinance is a huge platform that's used across Bangladesh or India as well. So have those kind of action plans been used for female sexual reproductive rights?
Maybe you can rephrase the question.
So in terms of access, I know there's like linked programs with providing, for example, microloans. We also contraception or even promotion, health educational workshops. Do you have much information on that, and if that's being used across the region or even in Africa or other parts of the world?
Yeah, I think that indeed a number of the governments utilize many methods. So they use, I think, a mix of public delivery as well as private delivery. I do know that in one of the studies that we did, social franchising was one of those mechanisms utilized in order to reach areas that the government could not go into. The other is, of course, utilizing volunteers like the lady health workers to reach access to, provide family planning services to women. So the government often uses a mix of methods, in order, it's just not done through just their own vehicles or own mechanisms. However, we can also question whether such methods where social franchising, for example, like I think it's Green Star, which goes into different countries like Bangladesh and Pakistan, whether this is actually effective, because social franchising mechanisms often move to areas that can create some form of return, right? Because they pay for some parts of it and the user has to pay for some parts of it. So if we are talking about reaching the more marginalized and the more poorer communities, these mechanisms may not move into those communities.
Yes.
I'm Dr. Bull, working with Taylor's University. Yeah. So first of all, it was a very nice presentation. I hope it's you said it's a draft that you're writing some report and
Yes, yeah.
about this thing. So actually, I got many, like 9 or 10 questions, but I'll just I'll be just asking just few maybe later. Actually, I can share with you at your place at Aero, because there are some kind of the data. So you're talking about this CPR, contraceptive, like 35.4% in Pakistan for the females and the 9 to 10 for the male. So I was wondering whether you have got this data through your own survey or it is coming through the DHS.
Yeah.
So
definitely we use the demographic health survey, because in order for us to compare across countries, we have to use the same uniform data set. So the DHS provides one of that. The other one is the World Contraceptive Use data. So where the DHS is available, we use the DHS simply because it gives a lot of insight into the behavior, right? The reproductive behavior. Yeah.
Sorry, why I'm asking, because I mean personally, you got it from DHS, but I don't believe the data. In a way, I have been working here like many years, but I'm from Pakistan actually, and I've been working with the United Nations there. So the way sometimes the data is being collected, it's just like you were saying that you say a person who has got this literacy rate, it's not they apply for the antenatal care. So if there's only one visit, they include it into the antenatal care, but not all the visits are those which are standard required are included in this. And I also could not find the antenatal care. How much is in your presentation about the Pakistan antenatal care one, and there was not only on the data for MMR in Pakistan, how much is the maternal mortality ratio there, and there are a few more inputs that I may be discussing with you, like the reasons that you listed for the risk for the HIV/AIDS. There was one, and then another was about this STIs are getting the the early childbirth reasons for. So there are something more beyond that kind of that are being discussed and recognized. Yeah, maybe I'll be discussing later on.
Yeah. Can I push you a little bit on that? So if the DHS and we all know that it's a compromised situation. What would you suggest are better sources of data to use?
No, just like Ms. Sawaz said, for example, just like when you talk about the Green Star, we already know that they go into the very already kind of, they don't reach out to all the places there. So in the DHS also there are the places that they cannot reach it. Yeah. So we have always to use like that different methods to reach out there. Yeah. For example, it's not only the officials that can reach out there. When I was working with the polio program there, the government officials could not go there. But because, like for example, when you got your own kind of access to the community, to the marginalized, there are places where there is a no-go area, there is a place where there is really rural area, the tribal conflicts are going on, there are some kind of religious. So the the traditional, not governmental, there are the ways in which you can reach the data, you can validate the data. So that's why I think that maybe, if AERO is working in Pakistan in some areas, how you have been able through your own resources and the linkages to collect the data. Because the final aim of all, so we are to discuss it to make it more reliable, more validated data. That's what we want.
So but I think that to add on to that, I think the DHS generally tries to create a sample, and that sample is representative of all of those quintiles and everything that they're studying. And usually I think the base for the DHS is almost like maybe 100,000. I know it's 100,000 in India. I'm not sure how many it is in Pakistan. So it is more or less supposed to be representative, but of course you're right, it may not be having access to places of conflict and all of that, and may not take that into consideration, because I think even like Sri Lanka, I remember that the MMR reported for Sri Lanka only takes the best for the years of the conflict of the Tamil Tigers. They never actually took the north and the east data into that. They only took the area for which they could access. So they claimed it was for conflict, but of course the numbers would change. I think the same is true for Afghanistan, right? So it might be true for, but I must look at the PDHS. So the PDHS is different. The Indian DHS is different. The Indian DHS has state by state by state, whereas PDHS, there are, I think, some areas that are captured. So you can see the difference between, I think, Sindh and maybe Khyber Pakhtunkhwa, you can see some of those differences. I think so, but it may not be specifically in every data set we will see it.
Yeah, actually, I'm really happy for this comprehensive presentation. In the two things that you mentioned, you said that sometimes this data is not representing the whole country.
Yeah.
Like when you say MMR for India or Malaysia or Pakistan, it's not through all the different regions. So this is a good thing. The another thing, just last comment that you said, it's a political will.
Yeah.
It's really the political will that changes. So that has been a little unfortunate for Pakistan. Let us see the new political government, but what is it?
Yes.
Hi, good morning. My name is Sharon Wilson. I'm from University of Brahman. So I'm just wondering, you've spoken about pregnancies and abortions and antenatal health, but the fundamentals of it all is menstrual health. I'm wondering, where does it sit in this big picture?
I think that we did not tackle menstrual health as a separate issue by itself. I think we cover it under comprehensive sexuality education, but this chapter is written by my colleague and not myself, so yeah. So, but I think that you mean understanding the pregnancy cycle, is it? Whether adolescents actually recognize that they are pregnant or not?
No, I asked this because we are, my colleague and I, we also are volunteers in an NGO called the Endometriosis Association of Malaysia. And we have data to show that one of the cause for infertility is endometriosis. And that comes down to menstrual health. So I'm just wondering, because you mentioned contraceptives and family planning and all that related to fertility. So I'm thinking, are we not looking at menstrual health and its relatedness to fertility?
I think definitely this is a very good point, because when we talk about family planning, people are looking at prevention of pregnancy, but there are actually many women who want to get pregnant but are unable to get pregnant. And what is it that the government actually does? I mean, like, whether the government does policies in order to fulfill the fertility preferences of individuals and couples. This is a big question, right? So it is not only identifying the underlying causes of infertility, and then there's also the other thing, which is secondary infertility. So after you have one child, you may actually desire to have 2 children, but you have 1 child, and then people say, well, you already got 1 child, but so if you don't have the secondary infertility is even more not recognized. I do believe that we do cover it in another section, which is infertility, but not under menstrual health. Yeah, and also endometriosis, endometrial cancer is in the reproductive cancer section also. So maybe when we finish that, but from another time.
But just to add to that, it's only been literally in the last 2 years that WHO is picking up infertility as an issue. There's been a lot of resistance to it because of the need to control the population rather than not. But I think that with the rights movement and so on, that there is much more of a pushback, and the difficulty then is actually trying to find funding for the research and so on to inform the infertility question. And it's been, if you look at the treatments here, even just doing a scan of in Malaysia, to go to an infertility doctor is you're selling your soul to have a child. So it is, that is, I think there is a slow shift, but then when it comes to then looking at trends, that will take us a little while to catch up. Any further questions? Last one?
Yes. It's more like comment. I'm Isni, Dr. Isni from now in KKN, in the Ministry of Health. I'm working in Sarawak. So, which is, because I'm dealing with all the pregnant mothers, all the maternal death, all the morbidity and mortality of the adolescents over there. So, you're right, there are a lot of non-Muslim over there they still had adolescent pregnancy first, but it means like some of them is like their culture or the society already trained them to be like that. Some of the parents just you have a girl, you get a boyfriend, so I'm out of the control. You're with your boyfriend already, so I didn't responsible of anything because of you. But in Sarawak also, in Ministry of Health, I think in Borneo side, we have like one-stop teenage pregnancy committee, whereby we try to settle their welfare. Okay, there's a police inside that one. The police officer and health side, and also the residents of the Sarawak, and then from the hospital side. So we try to help of the welfare of this adolescent pregnancy. Some of it can be settled. We try. They are in love. They want to get married, but in some law they are not allowed to get married before certain age. Okay, so they are cohabiting until age of 18 because no one want to sign responsible for them. Okay, so the girl will at risk to be left. If the boyfriend, unlegalized husband or something like that, it's left the pregnant women usually get one baby 2 years, 3 years. Okay, before 18 years old, he will find another girls. If we find a problem like that, then we refer to the welfare department or something. So there's a lot of issue, and we in health side we also educate our students in our young generations about education in sexual health. Okay, but there's limitation for us also. How far should we go, because there's MOE, Ministry of Education, they are not allowing us to go to that far. This is contraception. Then the teacher was, why are you asking me, like allowing the girls to know about this? They will do the sexual intercourse, something like that. But I think there's a big issue might be debated from the ministry, the top down itself. But I think this platform will be great. There's the evidence, everything. We don't know the exact why. Our educated, although they are in rural, they still have school. They know they're right, but they still have sexual intercourse and get pregnant. So how to convey them? They know the knowledge already, because we have the RCB, rural curative village doctors that go all with boat, with flying doctors, go to search for the school and give the talks. But still, it's not like 100% 100% working. So there might be a way, like we expose all the teenager or the adolescents about the contraception. They might not know about this thing, and they don't know the rights. But some contraception, for say in Depo-Provera, the IM injectable one, is not good for adolescents because they are keep growing. The growth spurt is not completed yet. So they are arguing like, if you give this one, they will disturb their growth spurt. So the last choice is IUD, which is unfavorable for these youngsters. So it's still debatable, but for the cases that we included in the committee, we tried to get them ISD, okay, and we remove until 18 when they are safe, can get married or and safe delivery, because we have very high morbidity due to teenage pregnancy. That's the real situation in Sabah and Sarawak. And also maternal death also is one of the factors, is teenage pregnancy, which is correct with the timeline. I think I should congratulate you with all the evidence, so I can boost up with the evidence to my team also, and try to improve whatever we can. Yes.
Thank you very much. Okay, no more questions?
Can I know that is there any successful implementation of comprehensive sexuality education in any country which empower all these youngsters in assessing all these SRH knowledges and also rights, so that it reduces most of the issues and social problems that you have mentioned?
Yeah, so I think that last year or so we held a regional policy dialogue, which we invited 13 different governments as well as NGOs to talk about the implementation of comprehensive sexuality education. It's very interesting to see that, when you take them out of this UN negotiation space, that actually there are quite a number of governments who are really committed to providing comprehensive sexuality education. We had governments, I think even like Cambodia, which said that, first they implemented, then they lowered the age, so there are governments who are very concentrated on this. Vietnam and Cambodia come to mind, and I think that we are still in a process, and when the government does it, you actually enjoy scale. So there are some very beautiful and small comprehensive sexuality education programs. I think that this was, I think in many of the research you can find it. What is it, US organization? Name doesn't come to me, but they had done it in Thailand and India, and it's high quality, but it's small, right? But you have the governments doing it in Vietnam and Cambodia, Mongolia is also committed, China. In fact, all of them were doing it at some level or another, right? And so it is possible. right? So we should also move our government to providing that, because I think that is the antidote to your question, right? If people have the knowledge and people have the information, they can protect themselves from STIs and HIVs, and they can also protect themselves from pregnancy until they are ready. I mean, if they're not ready for pregnancy, how on earth are they going to be ready for taking care of a child or a family, right? And so that's one. The second one is, of course, that we have to change our attitudes, that we should not bring our own moral predisposition into it, but try to do the best for that person in that situation, right? And that involves educating them. Sometimes it means us educating ourselves as well. I mean, I have teenage children. Yeah, it frightens me that, you know, my child watches and emulates Cardi B or something like that, right? I mean, like, it scares me, right? So, but nevertheless, that's their life, right? And that is their world. So we have to like say, oh, how am I going to adapt myself to it, and how can I make sure that she gets the best that she needs, right? And he gets the best that he needs. I wouldn't think that all of them actually, just because they're having sex, means they have full and comprehensive and quality information that they need, because I think there was a study which was even in like amongst medical students, male medical students, a very small percentage had full information or understood their own sexuality. You know, so I mean, like, you're talking about somebody who's gone all the way to medical school and doesn't have that information. So for us to go and say, oh well, because they're having sex, they have that information, is maybe it's a big leap we are making there. So to make sure that they have that right to know, and to know that they have options, right? Just because generations before them got married early and had this, and so this is about female sexuality behavior, right? So we think that girls can be sexual, they can get married young. Why? Because that's their whole domain. That's the all the things that they can fulfill in life is to be a wife and a mother. So whether you do it at 13 or 15, you're getting to that goal. So to actually educate girls that they have so many different options, you know, and taking care of their sexual and reproductive health as an integral part to achieving all of those options is a different mindset change that is required.
I think that is a lovely note on which to end. That shows the complexity of the issues, and that there isn't a single solution. Comprehensive sexuality education on its own is not enough, and that we need the responsibilities from all of us as providers, as parents, as members of the society, as well as the children themselves, enabling them and enabling the environment, and so on. So can you join me in thanking Siva for a wonderful and Makan downstairs. Please join us. And we hope to see you at our next seminar. Please keep an eye on the website. Why can you do it from there and not from there?